The topic under discussion for this session is hemoglobin abnormalities, which is important and clinically relevant. Tissue hypoxia often exists in our patients despite normal blood gas results. Hemoglobin abnormalities are often the source of this hypoxia. Therefore, it's necessary for respiratory care practitioners to develop expertise on these conditions. Now, please understand that you must listen to all of the audio and visit all of the required web links to receive credit for this lesson. Time has been allocated within the lesson for you to do so. The non-required links are marked as FYI. Here is your learning objective for this session. When we finish here, you will be able to explain the etiologies, pathophysiology, manifestations, diagnosis, and management of hemoglobin abnormalities. We're going to begin our discussion with a review of the structure and function of hemoglobin. The purpose of this review is to ensure the knowledge base for forthcoming information. The hemoglobin molecule contains 4 heme groups, each of which has an iron atom. One molecule of oxygen can bind with each of these heme groups. The number of oxygen molecules carried by hemoglobin determine its saturation. A molecule of hemoglobin that carries 4 molecules of oxygen is 100% saturated. A molecule of hemoglobin carrying 3 molecules of oxygen is 75% saturated, and so on. At 100% saturation, 1 gram of hemoglobin carries 1.34 mLs of oxygen. So at 100% saturation, 15 grams of hemoglobin carries about 20 mLs of oxygen. At a PO2 of 100, on the other hand, 0.3 mLs of oxygen is carried dissolved in the plasma. This is the amount of oxygen carried in the blood that is reflected by the PO2, or partial pressure of oxygen. So obviously, survival would not be possible if one had only the oxygen carried dissolved in the plasma, at least at ambient barometric pressure. Without hemoglobin, the cardiac output must increase to 36 liters a minute for the same oxygen delivery. Hemoglobin functions 3 different ways for oxygen transport. It binds oxygen for the transport, it transports the oxygen to the tissues, and it releases the oxygen to the tissues. Interference with any of these functions will result in tissue hypoxia. In addition to its role in oxygen transport, hemoglobin serves 2 additional functions. First, it is a buffer. Second, in importance only to bicarbonate. Then, hemoglobin transports carbon dioxide. Importantly, hemoglobin carries the greatest amount of carbon dioxide that is exchanged or excreted. This is the oxyhemoglobin dissociation curve, which describes the relationship between the PO2 and the saturation. There are 3 points on this curve that we all ought to know. First, at a PO2 of 60, the saturation normally is 90%. At a PO2 of 40, the saturation is 75%. And at a PO2 of 27, the saturation is 50%. This is known as the P50, which is used to identify shifts in the oxyhemoglobin dissociation curve. The relationship described by the shape of the curve is physiologically advantageous. As you see on the upper part of the curve, hemoglobin has a greater affinity for oxygen, which facilitates uptake of oxygen in the lung. At the lower portion of the curve, hemoglobin has a lesser affinity for oxygen, and this facilitates release of oxygen to the tissues. Although we might consider shifts in the HbO2 curve only of academic interest, this is not the case. These shifts imply deviations from normal HbO2 function, therefore these have clinical significance. A shift to the right implies a lower saturation for a given PO2 with an increase in the P50. Again, a rightward shift in the curve produces a lower saturation for a given PO2. Although this may appear to be harmful, in fact, rightward shifts improve tissue oxygenation by facilitating release of oxygen to the tissues. Circumstances that shift the curve to the right include increased temperature, increased PCO2, this is known as the Bohr shift, increased hydrogen ion concentration or decreased pH, and sulfhemoglobin. We will address sulfhemoglobin in detail later on. Leftward shifts in the curve imply a greater saturation for a given PO2 as well as a decreased P50. Again, leftward shifts in the curve imply a greater saturation for a given PO2. Intuitively, we want to think of this as advantageous, but it is not, because leftward shifts interfere with release of oxygen to the tissues, causing tissue hypoxia. Circumstances that will shift the curve to the left include decreased temperature, decreased PCO2, increased pH or decreased hydrogen ion concentration, and then fetal hemoglobin, and decreased 2,3-diphosphoglycerate, which is associated with stored blood. 2,3-DPG helps the hemoglobin unload the oxygen to the tissues. Hemoglobin is transported within the red blood corpuscles, which are produced by the bone marrow. Erythropoietin, a hormone which is produced by the liver and the kidneys, stimulates the bone marrow's production of the RBCs. Therefore, liver and kidney disease can cause anemia through failure to produce this hormone. The RBC has a life cycle of about 120 days. At about 120 days, then, the iron in the hemoglobin is recycled. The recycling byproducts of this iron include carbon monoxide as well as bilirubin. Therefore, you know that trace amounts of carbon monoxide are produced by the body. The hemoglobin saturation with oxygen can be measured directly or it can be calculated. The calculations are based on the HbO2 curve. Importantly, the calculated saturation does not account for things like carboxyhemoglobin, methemoglobin, or sulfhemoglobin. But, as we will explain later, most co-oximeters also do not detect sulfhemoglobin. In the sections to come, we are going to discuss hemoglobin abnormalities. Here's a list of the abnormalities that we will describe: polycythemia, anemia, carboxyhemoglobin, methemoglobin, and sulfhemoglobin. We will begin our discussion of hemoglobin abnormalities by talking about polycythemia. Simply put, polycythemia simply is too many RBCs. There is primary polycythemia, which is caused by a genetic mutation in hematopoietic cells. This is a rare condition that is also known as polycythemia vera. Then there is secondary polycythemia, which is much more common. This is caused by factors extrinsic to the RBC precursors. Then there is relative polycythemia, which is decreased plasma volume, therefore concentrating the RBCs. Now we'll take a look at the underlying causes or etiologies of polycythemia. Primary polycythemia or polycythemia vera, problem lies within the bone marrow. This is classified as a myeloproliferative disease. The origin is either with an inherited mutation or an acquired mutation of the chromosomes. With secondary polycythemia, the problem is outside of the bone marrow. One of the underlying causes is chronic hypoxemia of numerous sources. Any or all of the following can cause secondary polycythemia. Residence at high altitude because of the low PO2. Cardiac disease, lung disease, chronic hypoventilation, smoking due to chronic carbon monoxide poisoning, congenital methemoglobinemia, and congenital 2,3-DPG deficiency. Other causes of secondary polycythemia include the hypersecretion of erythropoietin, which could occur with a renal tumor, androgenic steroids, and in newborns with polycythemia, it can be due to fetal asphyxia. Up to a point, polycythemia can be advantageous because it increases O2 carrying capacity, but polycythemia can be quite detrimental. The detrimental effects include expanded blood volume, increased metabolism, and increased blood viscosity. This increase in blood viscosity can lead to increased myocardial work as well as an increased risk for thrombus formation. Here are some of the symptoms of polycythemia. That is headache, weight loss, weakness and or malaise, bruising, bleedings of the gums or bleeding of the nose. Additional symptoms include itching or pruritus, which can be severe, especially right after a hot shower, joint dysfunctions, and gastrointestinal discomfort, including constipation. The physical signs of polycythemia include rubor or redness, especially in the face, hypertension, hepatomegaly, splenomegaly, and frequently ecchymoses or bruises. The diagnosis of polycythemia is made on the basis of patient history, physical findings, and laboratory studies. Historical factors may include a median age of around 60 for primary polycythemia, a family history of blood disorders, residence at high altitude due to the low PO2, and there may be a medical history of cardiac pulmonary disease and or pulmonary disease. Laboratory studies are needed to determine the type and cause of polycythemia. First, an increased RBC mass is diagnostic of erythrocytosis. Then erythropoietin levels distinguish between types. EPO levels are normal in primary polycythemia because the polycythemia emanates from the bone marrow. EPO levels are elevated in secondary polycythemia because the EPO is the stimulus for RBC production. Plasma volume measurement is done to rule out relative polycythemia. The complete blood count for a patient with polycythemia will reveal elevated RBCs and hemoglobin, but also sometimes the white blood count as well as the platelet count will be elevated. It may be helpful in some patients to do arterial blood gas to identify hypoxemia as an etiology, and even the carboxyhemoglobin for the same purpose. The common complications of polycythemia are these. First, there are thrombotic events, such as deep vein thrombosis, stroke, even myocardial infarction. Heart failure can come from the increased viscosity of the blood, increasing the work on the heart. Kidney stones and hemorrhage may also complicate polycythemia. Now we'll turn to management of polycythemia. The treatment for primary polycythemia is palliative, that is, there is no cure. One of the palliations includes phlebotomy, which is done to maintain normal cell mass and also to control blood viscosity. In some patients, chemotherapy may be useful to suppress bone marrow production. The management of secondary polycythemia may also include phlebotomy for the same reasons, that is, to maintain a normal cell mass as well as to control blood viscosity. However, secondary polycythemia may be cured. It may be cured by treating the underlying cause, such as relocating to a lower altitude, the administration of supplemental oxygen to correct the hypoxemia, smoking cessation to avoid the carbon monoxide poisoning, things like BiPAP for chronic hypoventilation, surgical correction of cardiac defects, and also surgery for renal tumors. Next, we will proceed to a discussion of anemia. Anemia is the opposite of polycythemia because herein we have deficient RBCs. The etiologies of anemia can be inadequate production of the RBCs, hemolysis or increased destruction of RBCs, as well as chronic blood loss. There are various types of anemia as classified by their etiologies. These include anemias due to dietary deficiency, such as deficiencies in vitamin B12, folic acid, and iron. Autoimmune disease can also cause anemia. Examples include autoimmune hemolytic anemia and also drug-induced immune anemia, where a drug causes an immune reaction to the RBCs. Then there is also secondary aplastic anemia, which is bone marrow depression from an external source. This can be caused by chemotherapy, by immunotherapy, and also by toxins such as benzene. There are also hereditary forms of anemia where hemoglobin variants are genetically transmitted. Each of these leads to varying degrees of hemolytic anemias triggered by different physiological circumstances. These include G6PD deficiency, thalassemia, and sickle cell anemia, which is primarily found in people of African descent. Another hereditary anemia is known as porphyria, which is found in Europeans. There are those who believe that signs and symptoms of porphyria gave rise to legends of vampires and werewolves. The manifestations of anemia include a pale color, chronic fatigue, shortness of breath, and the laboratory will show decreased RBCs and hemoglobin. The management of anemia focuses on restoring the RBCs and the hemoglobin. From the standpoint of a respiratory care practitioner, It's critical that we always consider a patient's hemoglobin level as part of their oxygenation status. Management of anemia may include blood replacement. For other patients, erythropoietin may be administered to stimulate RBC production. For your information, although Jehovah's Witnesses cannot accept blood, it is permissible by their religion to accept erythropoietin. Some anemias also are managed by addressing underlying causes. This may be by improvement of nutrition or avoidance or removal of toxins. Other management strategies remain rather controversial. The next hemoglobin abnormality we're going to discuss is that of carbon monoxide toxicity or carbon monoxide poisoning. As I mentioned earlier, a trace amount of carbon monoxide is endogenous or produced by the body. Otherwise, carbon monoxide found in the blood is inhaled as a byproduct of incomplete combustion. Carbon monoxide, as you know, is both colorless and odorless. The physiologic level of carbon monoxide in the blood of a non-smoking rural dweller is about 0.2%. However, this value will be greater in smokers as well as in city dwellers. Now, I would bet that every respiratory therapist who worked in the emergency room has encountered carbon monoxide poisoning at least several times during their career. Carbon monoxide is the most common fatal poison in the United States, inhaled either accidentally or suicidally. Carbon monoxide binds with hemoglobin with a bond that is 240 times stronger than that of oxygen. It also binds with myoglobin, therefore causes myocardial damage. Carbon monoxide also shifts the HbO2 curve to the left, which interferes with the release of oxygen to the tissues. If all of that wasn't bad enough, carbon monoxide also stimulates the release of nitric oxide endogenously, which increases free radical formation, therefore oxidant injury. Carbon monoxide also has a greater affinity for fetal hemoglobin, therefore is very likely to induce fetal asphyxia. This table shows the signs and symptoms that are associated with increasing levels of HbCO. 0 to 10%, there may be no signs or symptoms. 10 to 20%, a mild headache, possibly angina and dyspnea. 20 to 40%, severe headache, dyspnea, weakness, and cognitive impairment. 40 to 60%, fainting, tachypnea, tachycardia, convulsions, and coma. And greater than 60% likely coma, shock, death. On physical examination, a patient with carbon monoxide poisoning is likely to show tachypnea and tachycardia, possibly a cherry red coloring. The diagnosis of carbon monoxide poisoning must be achieved by measuring the carboxyhemoglobin level, and this can be done with standard co-oximetry, and it can also be detected by currently available pulse co-oximeter monitors, and all emergency rooms should be equipped with these to detect carbon monoxide poisoning. This slide shows one brand of pulse co-oximeter. This is the Masimo Rad 57, which will monitor the oxyhemoglobin, the carboxyhemoglobin, as well as the methemoglobin. I believe that every emergency room should have some type of monitor like this. The management of carbon monoxide poisoning is oxygen therapy and, for some patients, hyperbaric oxygen. 100% oxygen inhalation will decrease the HbCO by 1/2 every 60 minutes. If the patient's carboxyhemoglobin is greater than 10%, then 100% oxygen should be administered until the HbCO is less than 5%, and that should be about 1 hour. If the HbCO is greater than 40%, then the patient should be transported for hyperbaric oxygen. Pregnant patients, especially women, should receive hyperbaric oxygen if their HbCO exceeds 30%. The next hemoglobin abnormality we'll discuss is methemoglobinemia. Most respiratory therapists have encountered this clinically, whether they knew it or not. Methemoglobin is hemoglobin that has been oxidized to the ferric state. Importantly, methemoglobin does not transport oxygen, nor does it transport carbon dioxide. Methemoglobinemia can be a congenital condition. This is congenital cytochrome B5 reductase deficiency, of which there are 4 subtypes. These people chronically have a cyanotic blue-gray color, otherwise they are likely to be asymptomatic. I vividly recall one patient that I encountered in an emergency room who had this congenital defect because when I measured his methemoglobin, it was about 8%, and I showed this to the ER doctor, and the ER doctor informed me that indeed this patient had the congenital form of methemoglobinemia and not to worry about it. As I said earlier, congenital methemoglobinemia is rare, so that when we see methemoglobinemia in the hospital setting, it is almost always acquired. And methemoglobinemia can be acquired through exposure to nitrates, as in food preservatives, and from street drugs, poppers. We can also acquire methemoglobin by exposure to dyes known as aniline dyes. One could also acquire methemoglobinemia through exposure to silver nitrate, which is a topical disinfectant, exposure to nitroprusside or nipride, as well as nitric and nitrous oxide. Also, exposure to antimalarials such as primaquine and inadequately cooked contaminated vegetables. Exposure to any of these can cause methemoglobinemia in some individuals. Of particular concern to respiratory care practitioners is iatrogenic methemoglobinemia, and that is because we are usually on the spot when this occurs. Iatrogenic methemoglobinemia usually occurs due to the application of local anesthetics, especially when applied to the mucosa. So we can be there when methemoglobinemia is caused by the administration of hurricane or one of those other substances for patients undergoing bronchoscopies or intubations. However, there are throat lozenges that contain benzocaine, and these also then could cause methemoglobinemia. Not all patients are susceptible to acquired methemoglobinemia. In fact, susceptibility is rare, confined to patients with congenital reduced methemoglobin reductase. Also, elderly patients and infants are inclined to susceptibility. Unfortunately, we have no means for anticipating this, and patients will develop methemoglobinemia without forewarning. Now we'll describe the manifestations of methemoglobinemia. The primary manifestation is cyanosis. If the methemoglobin level is greater than 10%, there will be cyanosis that is refractory to increased FiO2. If the level gets between 20 and 50%, the patient will experience anxiety, fatigue, and tachycardia. And at levels between 50 and 70%, the patient can develop coma and even death. Now, this is important for an RCP to understand, that in methemoglobinemia, the standard pulse oximetry is unreliable. The pulse oximeter will display a saturation of 80 to 85% even with a very high methemoglobin level. The diagnosis for methemoglobinemia needs to be made through co-oximetry, in which the methemoglobin level is directly measured. If you're interested, the link below will take you to a case of methemoglobinemia after a bronchoscopy, which is very interesting. Pertaining to management, it's important to understand that supplemental oxygen has absolutely no beneficial effect. We'll see a patient who's cyanotic, and their O2 saturation will be reading 80 or 85%, but increasing the FiO2 doesn't do anything. If the methemoglobin level is below 30%, it's possible that no treatment is needed. However, if the level is greater than 30%, then the usual treatment is administration of intravenous methylene blue, unless the patient has G6PD deficiency, which is a hemoglobin abnormality. Other forms of treatment can include ascorbic acid or vitamin C given orally, and also N-acetylcysteine or Mucomyst, which is also administered orally. This is off-label use of the acetylcysteine. Now, we're going to add a little more confusion to the abnormal hemoglobin picture by talking about sulfhemoglobinemia. This is another condition that we may have encountered without being aware of it. You'll understand why shortly. Sulfhemoglobin involves incorporation of a sulfur atom into the hemoglobin molecule. This condition is also characterized by cyanosis in the absence of hypoxemia. The etiologies of sulfhemoglobinemia include chronic constipation as a predisposing feature. Of course, we see this frequently in elderly patients. Exposure to aniline dyes, as in some paints, also can cause sulfhemoglobinemia in susceptible patients, as well as medications. The medications include sulfonamides such as Bactrim, phenazopyridine or pyridium, phenacetin, which is the P in APC, and also is included in Excedrin, and another medication called Dapsone, which is used to treat leprosy and malaria. Dapsone causes methemoglobinemia as well as sulfhemoglobinemia. As in methemoglobinemia, the primary feature of sulfhemoglobinemia is cyanosis. If you draw blood from a patient with sulfhemoglobinemia, it appears green or greenish-brown. Otherwise, the patient may be asymptomatic. Importantly, sulfhemoglobin does not carry oxygen, but since sulfhemoglobin shifts the HbO2 curve to the right, it may actually improve oxygen delivery to the tissue by increasing the release of oxygen to the tissue. The bottom line of sulfhemoglobinemia is that it usually looks much worse than it is. The most important problem around sulfhemoglobinemia is diagnosing it, because sulfhemoglobin is not measured by standard co-oximetry and is likely to be detected as methemoglobin and therefore treated as methemoglobinemia. However, there are some co-oximeters that can be software calibrated to measure sulfhemoglobin. So the diagnosis of sulfhemoglobinemia is usually made on the basis of a history of ingestion or exposure or chronic constipation, as well as cyanosis that is unresponsive to oxygen and also unresponsive to treatment with methylene blue, which would reverse methemoglobinemia. There is a link at the bottom of this page that will take you to a very interesting case of sulfhemoglobinemia. Management of sulfhemoglobinemia, while there is none, no intervention is necessary. However, we may need to stop whatever medication might be causing it and also treat whatever constipation is predisposing to it. That concluded the new information for this presentation. Now we will summarize and review. We began by talking about hemoglobin. We talked about its structure and its functions in carrying both O2 and CO2, as well as being a buffer. We talked about the production of hemoglobin in the bone marrow along with the RBCs, its metabolism, and we listed the primary abnormalities. We talked about polycythemia, that is excessive RBCs, and identified the etiologies distinguishing between primary versus secondary. We also described the manifestations, the diagnosis, the complication. Remember, the primary complication involves increased viscosity of the blood involving heart failure and thrombosis. And we also identified the management for both primary and secondary polycythemia. Anemia, on the other hand, is inadequate hemoglobin. Its etiologies can be blood loss or low production. The primary manifestation of anemia is deficient hemoglobin and red blood cells. The management strategies for hemoglobin include blood replacement as well as erythropoietin, which is administered to stimulate RBC production. We identified carbon monoxide as the most common lethal poison in the United States. The etiology is inhalation of carbon monoxide. The manifestations depend on the HbCO2 level. The diagnosis is direct measurement of carboxyhemoglobin, and management involves administration of oxygen, and for some patients it will require hyperbaric oxygen. Methemoglobin is hemoglobin that has been oxidized and therefore cannot transport O2 to the tissues. As such, it is non-functional. The etiologies include ingestion of nitrates or nitrites, as well as exposure to local anesthetics. Primary manifestation of methemoglobinemia is cyanosis that does not respond to supplemental oxygen. It must be diagnosed by directly measuring the HbMet, and then, if management is necessary, with intravenous methylene blue and possibly even with N-acetylcysteine or mucomist. Sulfhemoglobin is hemoglobin with a sulfur atom. Like methemoglobin, sulfhemoglobin also does not transport oxygen and produces cyanosis. Its etiologies include sulfa drugs, chronic constipation and exposure to some paints. The primary manifestation of soft hemoglobinemia is cyanosis. Also, there is brownish-green blood. The diagnosis of soft hemoglobinemia is difficult. The most important thing to do is to rule out methemoglobinemia. Currently, there is no management for soft hemoglobinemia. Usually, it looks much worse than it is.